So lucky to be joined by our next Clinical Pearl presenter, critical care PGY2 resident. I guess we should say almost like ex-resident as we're recording this at the end of June from Wesley Medical Center, future EM pharmacist there in Kansas, Nick Kim. So Nick, welcome. How are you doing today?
Doing great. I appreciate you, Nick, for having me here today. I'm really excited to be here to talk to everyone.
Pleasure's all mine. Talking about one of our favorite subjects. I think we just got to dive right in, right? Because, some of our most critically ill patients, right, when we think of our ICU players, that's those in severe ARDS. And as we work to treat the cause of that, there's a pharmacologic therapy that can help in the interim. At least we think it does. So, Nick, take it away.
Great. Thank you for that great introduction, and I'm happy to be here again. So, ARDS. So, this is really important and a really wide topic that we can talk about with ICU patients. So, ARDS is defined really as a life-threatening form of respiratory failure that has acute hypoxemia, and patients usually present with bilateral infiltrates. So this acute diffuse inflammatory form of lung injury is usually caused by this poor oxygenation and those pulmonary infiltrates and these non-compliant lungs. So overall, ARDS has really been and is associated with a high mortality, and there's not really a lot of effective treatments out there. So when we talk about ARDS, they also have its risks. So this risk of the development of pulmonary hypertension due to the pulmonary artery vasoconstriction as well. So interestingly enough, most cases of ARDS are defined in the moderate to severe range. So this is around 75% of cases of ARDS is in the moderate severe range. So a lot of these patients are really, really sick. But when we look at severity levels, we use the Berlin criteria to really define and classify these moderate and severe ranges of ARDS. So this Berlin criteria is really used to get this diagnostic criteria and identify, are they mild, are they moderate and severe or severe. So they investigate the timing of when these symptoms occurred, if these patients have chest x-rays with bilateral opacities, and if these patients have respiratory failure not due to other causes such as cardiac failure or fluid overloaded patients. When we look at other risk factors, they also identify if patients have pneumonia, if have secondary traumas, sepsis, and anything identified on echoes as well. When we look at oxygenation severity, they use PF ratios, so a PaFiO2 ratio, to identify mild, moderate, severe with the Berliner criteria. So if we look at the PF ratio of greater than 200 and less than equal to 300 millimeters of mercury, and these patients have to have a PEEP of at least 5, this is defined as the mild form of ARDS. In moderate forms and severe forms, the PF ratio is greater than 100 to less than equal to 200 in the moderate patients. And in severe ARDS, they have a PF ratio of less than equal to 100 millimeters of mercury. So when we talk about ARDS too, I think it's really important to talk about the pathophysiology. So when we look at the pathophysiology of ARDS, they have the severe refractory hypoxemia. So severe ARDS is the classification of the PF ratio of less than 100, like I just said before, with a PEEP of at least 5. And they have three different stages. They have an exudative stage, proliferative stage, and a fibrotic stage. When we talk about the exudative stage, this is really defined as cell damage, which is either be due to endothelial injury, alveolar epithelial injury, or ventilator-associated injury. So the endothelial injury, this part of the cell damage, this is due to the release of pro-inflammatory cytokines. This causes this increase in vascular permeability, and it recruits neutrophils and macrophages to that specific injury and accumulates protein-rich fluid in the lung air spaces. In alveolar epithelial injuries, these activated neutrophils migrate across the epithelium, then increase these mediators as they move across, contributing to the apoptosis and causes more damage to these epithelial cells. This really causes this fluid accumulation, impaired gas exchange, where they're really key signs and symptoms of ARDS. And third, the other kind of cell damage is the damage that we can cause to the patient, which is mechanical ventilation injury. So in this mechanical ventilation injury, the causes is worsening lung injury with the inflammation and edema due to these high volumes we have to give these patients with a ventilator. So with these high volumes or pressures, we can cause barotrauma or volume trauma as well to the end because of the repeated cyclic stretching of the epithelium and causes the pro-inflammatory pathways to activate and cause additional pulmonary damage. Overall, all three of these injuries can cause the alveolar collapse or de-recruitment and causes deoxygenation and gas exchange issues. That itself was just the exudative stage. So when we talk about the proliferative stage, this really begins once the damage to the lung endothelium and alveolar epithelium has stopped progressing, and this involves repair and reestablishment of endothelial and epithelial integrity. This edema is accumulated and reabsorbed during the alveolar function, and then it can cause a fibrotic stage if these patients don't improve in this proliferative stage, which is this distortion of pulmonary structures and fibrosis that can cause prolonged mechanical ventilation itself, which also may cause the injury in the future in the long run. So patients who have idiopathic pulmonary fibrosis continued and discontinued cyclic stretching of the alveolar epithelium can cause this profibrotic cascades leading to the apoptosis and fibrosis of the lungs. When we talk about refractory hypoxemia itself as well, this is like this inadequate arterial oxygenation despite optimal inspired oxygen. This shunting can occur due to this acute lung injury and cause a VQ mismatch due to the atelectasis, PE, or pulmonary edema, or even infiltrates as well. The hypoventilation can occur as well due to machine failure, and we have to really be aware of patients who have anemia, intracardiac shunts, decreased cardiac output, and increased demand states because this refractory hypoxemia is a big risk. So when we look at the new global definition that has been released recently about ARDS, this has been trying to expand the use of non-invasive support for patients who have acute hypoxic respiratory failure. So, patients who have high flow nasal cannula of at least 30 liters per minute can be included in this definition of ARDS now. So, the whole purpose of this new global definition is to really get this early diagnosis of ARDS in patients and to really see, okay, are we able to identify patients who have not as many resources? So, this allows the use of pulse oximetry instead of ABG's measurements. It also lets and evaluates changes for utilizing a modified definition that doesn't use PF ratios or PEEP and uses high flow nasal cannula in these resource limited settings. When looking at this global definition, it's really important this new changes to help expand our diagnosis and include more patients to make sure they get treatment faster as well. And one thing I really want to dive in real quickly before we dive into prostacyclins are some of these other treatments as well. So when we look at steroids, which is one of the key therapies in the guidelines, is suggesting the use in patients who have a PF ratio less than or equal to 300. So this is used in these patients early on, but can have harm when we use it later. And when we really look at the optimal regimen, it's unknown, but there are some studies out there, such as the DEXA ARDS trial, that looks at the dosing. Another different therapy we can use in ARDS as well is NMDAs, so neuromuscular blockers. So these are patients who can be, we use this in patients who have early ARDS, so less than or equal to 48 hours of mechanical ventilation with PF ratios less than 100. So we use this to really show that we can cause, we paralyze them to reduce the mortality in patients, to reduce the vent dysynchrony that occurs. We also want to make sure that we have stopping of paralytics earlier, just because when we have longer uses of paralytics, we can have increased neuromuscular weakness. So when we look at these therapies, they have conflicting evidence as well and benefits in ARDS. But now that we're done talking about those, let's go ahead and talk about the start of the show, prostacyclins. So one of the more important things to talk about with prostacyclins is seeing how do they really work? So prostacyclins itself are lipid mediators that are synthesized from essential fatty acids. These patients are given this prostacyclins inhaled to reduce the amount of systemic vascular vasodilation in comparison to IV forms. So one of the main ones we use is epoprostenol. There's Flolan or Velitri, which I'll go into a little bit later in this discussion. But epoprostenol itself is a PGI2 inhibitor. So this causes the promotion of pulmonary vasodilation via the cyclic AMP mediated decrease in intracellular calcium and increases the surfactant production. They really do this by reducing the obstruction of the pulmonary microcirculation in ARDS. And this is really important because they have anti-inflammatory properties by either suppressing TNF-alpha synthesis and also potential antiplatelet properties as well, which is really only shown with the IV administration, but it's not really known if the inhaled form has it, but we can't really rule it out yet. And one important thing to note, as we said with the other guideline therapies of NMDAs and corticosteroids, are what are the guideline recommendations on epoprostenol itself and prostacyclins. So in there, in the guidelines, there are no recommendations for adjunct or rescue therapy for prostacyclins. So why do we still use it in these patients? So based on some meta-analysis out there, I'm going to highlight one key one that's more recent in 2023 by Torbeck and colleagues. This concluded that 23 different studies have evaluated inhaled prostacyclins, and they showed that there was improved PF ratios with mean pulmonary artery pressures as well. When we go through this study, it evaluated, interestingly enough, patients who were with COVID-19 and non-COVID-19. So this patient data in this meta-analysis is very limited and has low quality of evidence overall, but overall it might have some benefits to patients who have ARDS, and there's not a lot of other therapies out there, so this is why it's used more commonly. Going past this study, one of the other therapies that the guidelines talk about is inhaled nitric oxide. So when we look at inhaled nitric oxide comparatively to inhaled bupropion, inhaled nitric oxide is addressed in the guidelines as the pulmonary vasodilator for rescue therapies, but there's no inhaled bupropion in there. So when we look at the comparison between the two, there is really no difference in PF ratios after 1 hour, no changes in safety, no changes in duration of ventilation, hospital ICU length of stay. So why do we start using ibuprofen over inhaled nitric oxide? They have this comparable efficacy, but when we look at the nitty-gritty, inhaled nitric oxide is very, very expensive, up to 17 times the cost of inhaled ibuprofen. So when we look at it from a pharmacy standpoint, these patients, you could be saving a lot of money by giving ibuprofen instead of nitric oxide. So this also has shown that inhaled nitric oxide may have more adverse events, either causing platelet aggregation, renal failure, or worsening hypoxemia as well. Now let's look into two main products of Flolan and Velitri. So we talked about this before. They're both inhaled epoprostenol products. So Flolan and Velitri are both epoprostenol, but they have a slightly different formulation. So Velitri contains a substance called arginine mannitol. So this causes the Velitri to be more stable at room temperature in comparison to Flolan. Flolan has to be put into the fridge. So in comparison to the two, this might have an operational benefits for some people. So Velitri can be benefited because you don't have to worry about putting it into the fridge and some other issues that might be occurred if a patient or if nurse or pharmacy technician or anyone puts in the wrong spot. When we look at the comparison of the two, is there really a big difference to use one over the other? There's not really much difference. But when we look at Flolan, there's a risk of it causing clogging of filters in the ventilation circuit due to the formulation of glycine in it. It's really, really rare to occur, but it can cause some more safety issues because this may limit other nebulized medications and interrupt therapy by replacing the filter very frequently. When we look at Velitri, has arginine, like we just said, but this arginine component can cause airway inflammation. So how does this occur? So arginine is a substrate of nitric oxide production, and this can increase the amount of substrate available to synthesize nitric oxide in the pulmonary vasculature when delivered. This might be beneficial to really increase the pulmonary vasodilation, but this can cause airway inflammation with the nitric oxide production. Now, next, we're going to be talking about weight-based and fixed-dose epoprostenol. So weight-based is the more common dosing, which is when we use 10 to 50 nanograms per kilo per minute, and we cap it at 50 nanograms per kilo per minute. And this is really because this shown that epoprostenol has a ceiling effect. So with the studies and the dosing, 50 nanograms per kilo per minute is kind of the max we go because there hasn't been shown any benefit when you go at a higher rate. More recently, there has been some literature that came out there talking about this fixed dose. So the fixed dose is a very interesting, different way to use epoprostenol. So they use a set rate of 8 milliliters an hour. And this 8 milliliters an hour is utilizing a concentration of 20,000 nanograms per nanograms per milliliter for maintenance dosing. When we look in comparison of the fixed dose versus the weight-based dose, the dosing is a lot different and we're getting a lot more epoprostenol in comparison. So When we look at the results of this study that looked at fixed dosing epoprostenol, they showed that they may have higher benefit and response in the first 4 hours of therapy, but later on, there has been no differences when we use this kind of therapy. So maybe we can use this in the future, but there has to be a lot more studies out there to talk about this. So next, one of the more important concepts for us is to really look about how do we really wean and use this epoprostenol. So once we get this patient to have this improvement in oxygenation, and we look at the different SpO2s, the PF ratios, and we determine this is a good time to start decreasing the epoprostenol. How do we do it? So there's a couple different ways. One of the ways is to wean it by 50% of the dose every 2 hours until it's off, and or back at the starting rate at 10 nanograms per kilo per minute. Another way is to really wean down 10 nanograms per kilo per minute every 1 to 4 hours until it's completely off, and then we discontinue the medication as well. Different ways to discontinue the epoprostenol, but different. It might be just based on you where you want to do it and what's best for your institution. So next, when we talk about epoprostenol, as any other medication, it has its benefits and it's also its side effects. So hypotension can occur. However, this is more seen with IV therapy of epoprostenol or in general of these prostacyclins. So when we use it for IV, it has more instances of blood pressure and hypotension, but not in comparison to inhaled formulations, not as often. These patients may get worsening cardiogenic pulmonary edema. So patients may get improved blood flow through the right side of the heart by increasing the preload of the left ventricle. This may be beneficial in a lot of these patients, but in patients who have LV failure, this may exacerbate cardiogenic pulmonary edema and just worsen their state. And then the possible benefits is this antiplatelet effect that might occur, like I said earlier. But at the same time, these patients who are actively bleeding, do we have to avoid the use of epoprostenol in them? That's something to consider as well. There's also that deposition in the ventilation circuit that I said before due to the glycine portion of the epoprostenol flowland. So attention to the circuit constantly is also needed. When we talk about the different types of or phenotypes, there's different hyperinflammatory or hypoinflammatory states. And there's really important to know who do we use this therapy for? Do we use it for all patients? When we look at epoprostenol and what patient and what groups really benefit the most from epoprostenol or prostacyclins in general, it's these patients who have either pulmonary arterial hypertension, group 3 pulmonary hypertension, patients with right ventricular dysfunction or heart failure, or patients with secondary ARDS, patients with sepsis, either multiple traumas, cardiopulmonary bypass, drug overdose, acute pancreatitis, and blood transfusions are really the main ones I would see. So when we look at patients who get prostacyclins, it's important that we kind of identify what is the reason of their ARDS. And maybe if they fall into this category, epoprostenol might be something that we want to reach for earlier. When we look at COVID and non-COVID, like we said in that study before, they have shown that they have used inhaled prostacyclins in it. But what is the benefit? So because of the potential benefit in antiplatelet and anti-inflammatory effects, there have been studies to show that there have been possible increases in PF ratios, some possible involvement in increase in oxygenation, and considered responders as well. So when we look at these studies, there are conflicting responses between patients who have COVID-19 who are using epoprostenol, but these patients may be benefiting from it due to this increase in oxygenation with this severe COVID-19 associated ARDS as well. Well, going through everything, I know that was a lot of information, but I think there's a lot of benefit to prostacyclins, but the data is very mixed. And I think that's the beauty of it. And that's what our role is to really determine who really fits using epoprostenol. So, and prostacyclins. So I think there are really specific patients that we really need to work on to identify who needs it, especially patients with secondary injury and the potential use in severe ARDS to really improve this oxygenation in those patients.
Nick, this was great. I mean, this is such a nuanced topic. I think you were able to cover a lot of our considerations, especially not only comparing to the inhaled nitric oxide, right, the classic other inhaled pulmonary vasodilator, but also kind of talking about those doses. So big thanks to you for coming on, sharing your time and knowledge. Greatly appreciate you, my friend.
All right. Thanks, Nick. I appreciate having me on this podcast. I had a great time.
Yeah, the pleasure is all mine.